Thank you very much indeed, Mr. President. I am extremely grateful to the Society for inviting me to this meeting. As you know, I have an amazing soft spot for both hematology here as well as KSA as a place for obvious reasons. So I thought before I start, I will put you through a quiz. And anybody who gives me the answers to the 3 problems that I will pose, and they are real problems, will get a mini cash prize from me if the society allows me to do so. In the first instance, I would like the junior faculty to see the questions and see whether they can answer them. And then if they can't, then we'll go to the senior faculty and try and embarrass them. So here is a real problem. Case number 1 is a 54-year-old man with type 2 diabetes, hypothyroidism, painful swollen legs, weight loss of 10 kilograms in a year, widespread skin rash, pain in the external ear and some redness. In the past, he had multiple clinic attendances and few admissions due to arthritis, arthralgia, skin rashes, and intermittent fevers. Dermatologists reviewed him and they said that he's got urticarial vasculitis. Full blood count shows hemoglobin for 149, white cell count is reduced at 1.2, neutrophils are 0.7, platelets are reduced at 117, skin biopsy was taken, and it is suggestive of a histiocytoid variant of Sweet syndrome. Bone marrow is suggestive of MDS or a myeloproliferative neoplasm. The karyotype is normal, and ultrasound shows a mild splenomegaly and low-level lymphadenopathy. Left ventricular ejection fraction is reduced at 22%, and myeloid gene panel, and that shows 40% VAF. In other words, there's a mutation involving a particular gene with a VAF of 41%. Autoantibody screen is negative. His brother was diagnosed at the Royal Free Hospital with familial Mediterranean fever, and he had the pyrin gene mutation and is on colchicine. So that's case number 1. Case number 2 is a 74-year-old nobleman who was previously fit. He presented with tiredness, and on examination he was anemic nil else, otherwise quite fit. White count was 3.3, neutrophils 1, hemoglobin 88, platelets 62, bone marrow slightly hypocellular, moderate trilineage dysplasia, blasts were 12%, myeloid gene panel showed 2 mutations, 1 constitutional with a VAF of 44% and another somatic in the same gene. He was started on 5-azacitidine. He responded well to this, and he continued with it for 18 months. It's just beginning to lose the response. So what I want to know is what's the diagnosis in this case? And the third one is a very interesting and very bright 30-year-old lawyer who presented with intense itching and tiredness of relatively recent onset, no history of infections, bruising, or bleeding. White count was low at 3.5, MCV macrocytic or 108, hemoglobin 12, platelets 150. She had a huge number of investigations for itching, and all of them gave negative or normal results. Bone marrow was consistently hypocellular, 30% cellularity, trilineage differentiation, blasts less than 5%, cytogenetics showed 7q-, and myeloid gene panel showed an ASXL1 mutation at a VAF of 8%. She was admitted with truncal ataxia and nystagmus, and she was very ill at that time, and she recovered after 6 weeks. Then she had a long-standing boyfriend, and she decided that she was going to marry him, and she was pregnant, and during pregnancy her itching completely resolved. She is now 7 years post and has a 3-year-old daughter who had pre-implantation diagnosis done for the disorder, and she is fit and well. So, for the mini cash prize, can anyone tell me all the diagnoses of all three cases? Case number 1. What do we think this case is? Does anybody know? Any offers on this one? And any offers on the lawyer? Okay. Well, I'll tell you at the end what they are, but if anybody during the lecture can get the diagnosis, please do tell me. Now, let's just think back, and before MDS, there must be a number of things that must happen that are reflected in the phenotype of hematopoiesis. And these things that happen, they are as a result of germinal genetics. In other words, what we are born with. And that is colored by what our exposure, lifetime exposure is. In other words, a combination of germline genetics and exposome, and then that exposure to whatever the environmental influences are, they will be cumulative over a period of time, and that's reflected in what happens with age, and as a result, what happens as we age. In other words, the aging process. And then, finally, we'll get somatic genetics into play, somatic epigenetics into play, and then sum total of all will be seen by the immune system, and that immune system over a lifetime develops its own memory. In other words, there is immunobiography. So the combination of germline genetics, acquired genetics, aging, what we are exposed to, and the memory that the immune system develops as a result of this, together constitute the environment in which the hematopoietic stem cell is in the bone marrow and is subjected to various pressures over a period of time. So in terms of what that means, I have selected 3 items that I would like to discuss in this talk, and those 3 are reflective of the 3 cases that I presented at the beginning. One is, what is the relationship between clonal hematopoiesis, which is defined as a variable allele frequency of less than 2%, and clonal hematopoiesis of indeterminate potential, which is defined as a VAF of more than 2%. Number one. Number two, how important is inflammation? In particular, how important is autoinflammation that can arise as a result of various genetic mutations, somatic or acquired, or as a result of environmental influences. So I'll give an example of that. And how important is the constitutional predisposition to the diseases? So we now know that when you look at aging, that unfortunately this pointer doesn't show, but if you look at this, it's now well recognized that as we get older, we develop mutations in a certain number of genes. The commonest set of genes that are mutated are shown there. They are DTA genes, that is DNMT3A, TET2, and ASXL1. They account for 2/3 of the mutations, and these mutations increase over a period of time. So over the age of 80, something like a third of us will develop these mutations. What is clear is that if we do have these mutations, then shown on the right-hand side there is that patients with these mutations die earlier. They don't die earlier only because they develop myelodysplastic syndrome or acute myeloid leukemia. They die earlier because all-cause mortality is increased in particular due to cardiovascular disease and cerebrovascular disease, which is shown below. Therefore, that indicates that this clonal hematopoiesis must arise early on and comes before overt MDS. But when clonal hematopoiesis has taken hold, that it has a number of consequences. Over a period of time now, there's a huge amount of literature that has come, that's been published through large number of studies. One of these is the 628,000 patients between UK Biobank and GCAD MyCode, which examined 40,000 patients who had CHIP. What is absolutely clear now is that there is a much higher incidence of a variety of diseases in addition to MDS, cardiovascular disease, hematological malignancies, lung cancer, gout, and COPD in patients who have CHIP. And our results that we are looking at serially, patients who are over the age of 60, are indicating that even in patients who have clone sizes of less than 2%, there may be a similar increased risk, at least in terms of propensity to cardiovascular disease. What is also becoming clear, certain treatments like CAR T-cell therapy, if patients have clonal hematopoiesis, then the risk of ICANS and some other complications associated with the CAR T-cell therapy are higher, and time doesn't allow to go into details of those. But what's also becoming clear is not all mutations are the same. Some mutations have a different phenotype, like DNMT is particularly associated with osteoporosis, TET2 and JAK2 with cerebrovascular and cardiovascular disease. What's also becoming clear that certain polymorphisms are protective against the development of CHIP, which is quite important. And certain traits go with the development of CHIP. There are about 20 genes that go with the development of CHIP. And also, there's a suggestion that the presence of CHIP may be protective towards Alzheimer's disease. The question then is it possible that we can interrupt the development of disease, whether that is hematological disease or non-hematological disease, in people who have developed CHIP? There's this elegant work from NIH in macaques, where they showed that, yes, indeed, with aging mice, that you can see, aging monkeys, that you can see that clonal hematopoiesis develops that affects DNMT3A, RUNX1, and TP53. But when you introduce the same kind of mutation by using CRISPR-Cas and introducing DNMT3A, TET2, and ASXL1 into these engineered clonal hematopoiesis, there is a marked weight loss and inflammatory phenotype that can then be inhibited by giving drugs like tocilizumab, and the monkeys gain weight again, therefore suggesting that there may be an element of reversibility in this. The next thing is that when does this clonal hematopoiesis develop? In other words, if you do want to interrupt this genesis, then when should you interrupt it? Now, this is elegant work from Cambridge, which was published in Nature, where they took patients with myeloproliferative disorders, mainly ET, PV, and myelofibrosis, who were diagnosed at different time points, and for whom they took blood or bone marrow. Then they prepared single-cell colonies from those, and they also had the constitutional source of DNA. Then they did the whole genome sequence of the colonies, of a large number of colonies. Having done that, then they identified on the right-hand panel at the end a certain number of mutations that occurred. And because this was single-cell genomics, you could go back to when these colonies actually developed, and you might have seen it, this was in lay press as well, that when you look at the phylogeny of these three patients demonstrate that in these cases, the JAK2 mutations and the DNMT3A mutation might have occurred very early on, almost in utero, as you can see at the time of post-conception, when the first time, either the blue line there or the red line there, when the first time the mutation was detected in the colonies when you look back. So therefore, this suggests that these mutations arise at a very early stage, and therefore a model is beginning to be developed, which is that you have first a constitutional predisposition, which is germline predisposition, and there are examples of that in the context of myeloproliferative disorders, some beginning to come in the context of MDS as well. And then you develop clonal driver mutations, not disease-causing mutations, but clonal driver mutations, eventually then developing disease-causing mutations, and then progression of the disease. Therefore, at any time where there is the flat line there is the prospect of interfering in order to stop the progression that can take place. The next thing is, what is the role of inflammation? So, elegant work from NIH, again this time, by a group who were looking at inflammatory diseases, described this condition elegantly. And this was a multi-center, multi-country effort to identify a disease where patients had presented with multiple areas in the body of inflammation, from eyes to ear inflammation, chondritis, to inflammation of the nose, to vasculitis, to involvement of the lung, and also the cutaneous manifestations in the form of vasculitis. Interestingly also, these patients had vacuolations in the bone marrow cells, both in erythroid cells shown here, as well as in some of the myeloid cells. And what it was shown is that this is due to a mutation which affects a ubiquitin activating enzyme, E1, characteristics of which are given there. It is on the X chromosome, and therefore the disease is predominantly seen in men than in women. The question then is, what is the connection between this acquired mutation, it's a somatic mutation that leads to this autoinflammation, and the development of MDS? So these are some examples of the patients that were presented in the New England Journal of Medicine paper, as well as in the NIH website, where vasculitis in the skin, injection site vasculitis. One of these patients was given canakinumab and developed that rash, those two pictures at the beginning. And very, very interestingly and more characteristically, this periorbital inflammation that occurs in these patients. And this again, this is the chondritis affecting the ears, the skin rash, the vasculitis with the neutrophilic infiltrate, lung infiltration with pleural effusion on the left side with lung involvement, and alveolitis in picture C, and vacuolation of erythroid cells. So something grossly wrong in terms of autoinflammation that is taking place. They don't have any organ-specific antibodies, so in that sense, it is not an autoimmune disease, it is an inflammation. So as you can see here, all the inflammatory markers in VEXAS are elevated, whether that is interleukins, there are so many of them that were measured, IP10, interferon gamma, etc. Now, when you look at these patients, how they are presenting, a quarter of them, at least at the top you can see, are presenting with MDS. They have trilineage dysplasia in the marrow. They may have thrombocytopenia, transfusion dependence, and again, a quarter of them show plasma cell dyscrasias with paraproteinemias, sort of MGUS type picture. And a significant number also have VTEs. The mutation has a hotspot. It affects methionine 41V, and the three mutations that are at the top, which are TAA, those are the dominant mutations, particularly the one which is with T. Again, you can see in the bottom panel that there is a DNMT3 mutation, TET2 mutation, T53 mutation, PPMID. The mutations that are associated with CHIP, they also are present in these cases. And what you can see on the right and the end there on the curve is that when you follow these patients up with VEXAS, they have a markedly increased incidence of development of clonal hematopoiesis over a period of time, which is also age-related, which kind of brings together this concept of inflammation and presence of MDS and interruption of inflammation may lead to prevention of progression. And what is interesting also is that some of these mutations go with a worse phenotype than others. For example, the one at the end, if you have that kind of mutation, there is a higher incidence of transfusion requirement and poorer prognosis. Same is the case in the mutation which is in the middle, whereas patients who have just ear chondritis only and have a mutation or at position 41 to leucine, they have a much benigner outcome. The only bit I want to show on this slide is the bit at the bottom, which is the panel D. This was elegant work which was published in Blood recently. And what it shows that is, if you look at the senescence phenotype, because there are now things that you can do, you can measure in the genome and epigenome a person's chronological age and biological age. So if you look at that genome of these patients, the genome is more senescent as the inflammation carries on. Now finally, just give me 4 more minutes. So that's the second. The final thing that I want to say is that you're well aware, and I'm very aware of the fact that because of consanguinity here, the incidence of those diseases that predispose to clonal hematopoiesis, MDS, is much higher. Out of these, telomeropathies are one where the telomere shortening occurs, except in POT1 mutation, and the commonest one of these is DDX41 mutation, which becomes commoner, as you can see in this slide, as we get older. So just a word or two about DDX41. It's a very important gene, and it is located on chromosome 5q, and it is both a constitutional genetic abnormality, but it manifests itself in later years. So I have a patient who is in his 70s, had a normal blood count, but had a DDX41 mutation, became anemic and was diagnosed. Typically, it is late onset, they have cytopenias, they have a hypocellular marrow, and they have a normal karyotype. They have good response to 5-azacitidine. And there is a kind of, if you look at the somatic mutation versus the constitutional mutation, there are hot spots of mutations that occur in the both germline sites as well as in the somatic sites, which are shown in these tall bars, red bars, the somatic ones, which is at position 500, and the blue bar, position 525. Then what's interesting also is that these mutations, particularly the constitutional mutations, they are true to form. In other words, Caucasians have a particular site that is mutated. The Japanese and Far Easterns have another site that is predominantly mutated. What I don't know, but you may know, is what is the site here, because that may be relevant. Now, this disease, the IPSS scoring doesn't work in this because it has a completely different prognosis overall, and therefore we may discuss later on in the meeting whether it should be a separate entity. Now, permit me, Mr. Chair, just to see whether people agree with the diagnosis. So the first patient that I presented, the 54-year-old, had VEXAS, and he had the mutation, and it was at position 41 in the UBA1 gene. The second patient, the Lord, and he has the mutation, DDX41, both a somatic mutation as well as a germline mutation. The last patient, which I didn't tell you about, has a bone marrow failure syndrome, has a SAMD9L mutation, and the reason why she got better is she developed genetic reversion. So with genetic reversion, you either lose the mutant or you develop a gain of function mutation or a loss of function mutation that neutralizes the effects of the mutant gene. So those were the 3 diagnoses. If anybody got it, I'm quite happy to give them the mini prize. Thank you very much indeed.